We're just giving it a few more minutes for people to join. We understand that you're jumping from one room to another. Thank you for joining us. And again, for those of you who's just joining, that link will allow you to enter the Jamboard that we will be using throughout our conversation today. And it'll make a lot more sense when we actually start this. And again, just thank you. All right. I think this is a good time to start. Again, my name is L.A. Alvarez. I'm one of the Associate PD here at Stanford, and we're very excited to share with you today some lessons learned in the past year on how the COVID-19 has affected medical education. I'm privileged and honored to be part of this panel today, and I'll have them introduce themselves as they start their talk. So again, I want to normalize that since the pandemic, things have not been easy. Today has not been easy. For those of you trying to figure out which Zoom meetings you're going to, and then you've ended up like going to the wrong Zoom meeting or that password was not working, welcome to 2021. We've had to adapt to so many changes, definitely. And it's as if work no longer has boundaries, right? Like for me, I don't know about you, I'm in the West Coast. And my time really started today at 6 in the morning because of other meetings. And really, that seems to be the normal these days, as opposed to back in the days before COVID, when our meeting would start at like 8 a.m. or maybe if you squeeze in at 7 a.m. And for those of you in the East Coast, I feel for you. I know that this is starting to be late for you. And by the end of 5 p.m. today, it'll be 8 p.m. your time. So I totally understand it. And as a nocturnist working only overnight clinical shifts, this is a big change for me as well. And so today, our goal is to highlight the effects of COVID-19 on the academic emergency medicine that's really relevant to medical education. We want to encourage you to join the conversation again via chat and also our post-it board. And again, that link for the post-it board is in the chat. And Evan Lawyer will be managing the chat to give us some time to answer them later on. And so let's start off with the impact of COVID-19 on curriculum didactics. So I'm going to ask each of the speakers again to introduce themselves when they first share their insights.
So hi, everyone. My name is Jeff Sakamoto. I'm one of the chief residents at Stanford. And to start us off, I think one of the biggest challenges of COVID was creating methods of learning despite being limited by social distancing and in-person contact. So as you all are very familiar with, lectures, grand rounds, simulation sessions, SAEM 21, and procedural education were all greatly affected. Most weekly didactics moved to Zoom or virtual formats, really changing the way that medical education was delivered. I think there were some other creative solutions, such as splitting learners into smaller groups to continue simulation education for procedures, or transitioning to virtual simulation.
Great. So, I mean, with all of these changes, what is working so far and what is not working?
Hi, everyone. I'm Kristen Nordenholtz. I'm one of the faculty at University of Colorado. Well, I mean, adapting to a mostly virtual conference worked pretty well, but did create a unique set of changes, some positive and some negative. Positive changes included much higher attendance. I mean, virtually everyone showed up. Less travel time to and from conference, there was none, and greater convenience. I mean, you could just roll out of bed, throw on some sort of a shirt, and show up. So, you know, that was great. More introverted learners who do not normally engage during conference now were able to do so through this vigorous chat discussions that were going on. And even members of this committee felt that it was easier to pay attention to Zoom lectures with more effective learning, and there was less distraction when you're not surrounded by all your peers. Some faculty and residents even said that they were able to do some light chores or exercise while listening to lectures, and this improved time management and well-being. So virtual participation did allow residents to attend conferences like Right Now, SAEM, AZEP conferences, and other national conferences without using up travel time or travel money. That was a good thing too.
Yep. So speaking of virtual conference, again, thank you for CDEM and Wellness Committee for sponsoring this talk. So surely there's a lot of positives that we're hearing about virtual conferences, and I'm sure it's not all rainbows and unicorns.
Yeah, I think there was also some negative sides to this. So some of the negative changes included maybe the potential for learners to not engage or listen, just given the lack of oversight or accountability through a virtual platform. And I think an even bigger issue is presenters may feel less interaction with the audience, specifically for lectures that required a lot of participation. So some things to combat this could be encouraging or requiring cameras, but this would also limit the flexibility of those watching the conference, although the benefits of on or on camera have been kind of debated. I think more importantly, there was just really a loss of camaraderie and a sense of community. And I think that's a theme that will be throughout this talk. I think weekly conference was really a time when residents and faculty who have a really busy shift schedule, clinical schedule, academic schedule, could have some time to just see each other and catch up with each other.
Yeah, Jeff, you make some good points. I'm Rita Manfredi from George Washington University in Washington, D.C., one of the faculty there. And Kristen mentioned that, maybe there were less distractions. And I would like to take the counterpoint to her and say that from a faculty standpoint, there's that ever-present temptation, especially during virtual grand rounds, to multitask. So I talked to a bunch of faculty around the country, and they actually said, yes, I did write up my charts. I did complete manuscripts. I did answer emails. So I think maybe we've become more distracted with the virtual platform.
That's right. I am certainly very distracted right now. So as we move forward beyond the pandemic, what do you think should continue?
Well, given that overall positive experience with virtual conferences, I think we could suggest a hybrid. Some department didactics are in person and some are online and in Zoom. And that way you get the benefits, the flexibility of both different formats. This helps improve resident wellness, also preserves time for the department to build relationships with the community, as well as hands-on simulation experience, things like that. For virtual sessions, we suggest encouraging participants to have their camera on for the maximum participation engagement. It's fun to see other people. It's very engaging to see other people, especially smile.
I think the other side to that, though, is I think, as we all are very aware, Zoom fatigue is a real issue, and multiple hours of consecutive sitting and listening to Zoom is quite fatiguing, at least for me. And there seems to be a concern for decreasing return on investments as you sit through more and more meetings. Something to maybe address this would be something we came up with is 20-20-20. So every 20 minutes of Zoom, you can take a 20-second break to stare at something 20 feet away to at least give your eyes a break for all these virtual meetings.
That's great, Jeff. And again, maybe considering alternating weeks of online Zoom conferences with in-person didactics will really help, as well as a lot of these hands-on sessions will be the sweet spots for medical education in the future.
Yeah, I think that might be the sweet spot because it offers the most benefit for all types of learners. And it might be useful for participants to have concrete learning objectives and content quizzes to maybe ensure that they are getting educated during these sessions. I think there's some other things to consider. Maybe how does this platform increase attendance? How effective was learning? One counterpoint from the resident perspective is that some say there's definitely been an increase in focus. And I think we talked about different programs have their own styles. Some require having their cameras on. There's also bandwidth issues. And then again, Zoom fatigue from sitting through all of these meetings.
And of course, the birds just like quacking in the background, like that's
totally
part of life now.
Going overhead.
Here's an example of utilizing technology in the virtual space, as well as multitasking. So let's see if there's anything on the board, in the post-it board. And again, I just put that in the chats, and then let's see.
So some things that have popped up on the board here, talking about how there is better virtual attendance with conference, and that we have had this opportunity to consider a virtual and in-person learning combination that we hadn't in the past. And there is this thing that we're all talking about, though, that people can be more distracted on Zoom.
That's right. Even the chats in the past would be very annoying as people are talking, and now we're encouraging you to get engaged with us and join us in our conversation. So again, plug. very meta here. Feel free to use the chat to add in your answers. How has COVID-19 impacted didactics and curriculum at your shop? And again, our goal is to kind of crowdsource from you as well, so that we can learn from each other, and also we can continue this conversation.
I'd
and
like
if
to
you go ahead, Rita.
Yeah, I was just, while we're on the posted board, I would just like to know if any of you out there, your residencies or your departments, have they already made the decision to go hybrid? And I would just like to see that. I just wonder if most everyone will go that route. So yeah, if you could sort of put your responses in the chat box, that would be super.
Yeah, I love the
Or on
idea
the
of
poster.
hybrid models. I know that at our shop, we're not going to go to completely hybrid. I don't know how you can be completely hybrid, but like not until next year, 2022. But for the past several months, we've been doing our procedural skills in person, and then the rest are virtually. That's true. Didactics has been negatively impacted by decreased participation. And again, the whole goal is to also try to figure out how you're going to engage the group using technology like this. Like you can use Jamboard, you can use just a regular Google document, or even just the chat function as a way to engage people.
And we found that moving to breakout rooms actually helped engagement. So if you had the group all together and then you split people off, they were sort of forced to interact. And that ended up being a way to get more engagement.
Yeah, I think that's a fair point. I think that what I'm noticing is while if you're an introvert, it's a lot easier to type, and that feels comfortable. I think there's something about that vulnerability piece that we miss during when we do these Zoom sessions. And so you're right, Rita, what I've seen people do is like at the very beginning, they break out into small groups and ask some questions that might make them feel a little bit more vulnerable. So I was just in a meeting prior to this, the equity and inclusion talk, and we started off the meeting with sharing like, what was your favorite restaurant? Or if you could be an Olympic player, like what kind of sports would you play? And like for me, I play zero sports. And so that was very easy to answer. But things like that to kind of create the sense of community again, as opposed to that transactional thing of just showing up. I love it. We're going hybrid at this point. A lot of it dictated by statewide restrictions in Illinois, and things are opening up. Definitely, I think that is a very big thing that we're noticing across the country. And so let's switch gears to recruitment, since we're talking about technology and the virtual space and curriculum. Surely it lends itself with using the same thing with all the pandemic restrictions, because recruitment of future residents also had to be adapted in the past year. Right.
So recruitment efforts were done virtually. Unfortunately, applicants really didn't have any way to evaluate the programs in person. And this really did change things quite a bit. Prior, of course, entire days were devoted to people coming and touring campuses, meeting faculty, residents, having dinners, going to the surrounding areas and seeing if they like your city. But COVID didn't make that possible any longer. And so obviously recruitment was all on Zoom, including the socials and the interviews and the dinners. So the main positive of that, of course, is, again, greatly reduced cost. And you could go to a lot of interviews in one day. You could go East Coast, West Coast, North Coast, South Coast, but there is no South Coast, is there? Anyway, but you know what I mean. So you could go all over the place. And so that it lended itself to increasing flexibility, and you got to see a lot of different programs. Also, another benefit, of course, is you got to spend more time at home with your family and friends, and you didn't have to travel.
Yeah. I'm going to piggyback on what Dr. Nordenholtz said, but I'm Jessica, and I'm one of the second-year residents at Stanford. I think, while the flexibility was great with the virtual recruitment, it did pose unique challenges of gauging this intangible, sense of belonging that new recruits often were able to assess whenever they were able to physically visit a program. I think applicants and recruiters felt it was much more challenging to create these natural conversations, to get to know each other outside of the formal interview environment, especially in these large group settings. Whereas before they would happen more naturally as you were mingling, just in a room or in a park or something like that. Our residency did try to do some things to address this. For example, themed social nights where we would do game nights or trivia nights or cooking nights in small groups or large groups, just to try to sort of bring in those, normal conversations and activities and do an experience that bonded people together. But I think despite this, many of our new interns and faculty members still felt it was difficult to sort of gauge their sense of belonging just virtually over Zoom at the prospective programs. Another thing that was mentioned that really brought people together before was food. I think it's something we can all sit down, enjoy a meal, talk about the food, enjoy that together. Now we're sitting in front of our computers, just sort of eating whatever we have. And we've lost that, something that can just unify us in the virtual format.
Yeah, I still remember the breakfast burritos that we would get for our conferences. And now I know in the past, like people would complain like, oh no, it's another breakfast burrito. I am craving that now. I wish I could have a breakfast burrito just so I can share that with everybody, right? So knowing what you know now, which adaptations will likely stay beyond this pandemic?
Well, again, I think there's opportunity for a hybrid model here with some Zoom getting to know you, and then some come and visit virtual presence. But more interestingly, and I think really importantly, I think we changed the focus of what we are trying to achieve with the interviewing process. So historically, our program was really trying to find people that were good fits. But the pandemic uncovered a lot of inequities in many facets of medicine, including the recruitment process. And so now it's great to hear that many programs have adopted a more holistic approach and are evaluating candidates on whether they have a focus of alignment with mission and vision and values of the institution, of the organization. This has some drawbacks also because, if you can do so many interviews and there's so many applications, the number of applications went way, way up. And there's still only, we can only do so many interviews. And so that is one of the drawbacks.
Yeah, and if we're going to be doing all of these Zoom interviews, we talked before about decreased engagement that can happen over Zoom. So that's something we'll have to address as well. To increase engagement, I heard of a couple residency programs doing sort of a waiting room experience where applicants were waiting for their formal interviews. Residents were just sort of in the waiting room to field questions in between the scheduled interviews and get to know the applicants, engage for those things that we're talking about. So that's something that could be recommended going forward. But I also do agree with the hybrid model. I think from the resident perspective, it could be nice to have the choice of the method of interviewing, whether that be saving money and decreasing travel time and interviewing on Zoom, and then possibly expanding to a second look in a program you want to see more intensely or invest in.
Yeah, I know that many residents of all different disciplines, wherever they're going into, have been encouraged to just max out the number of places they're applying to. So I just wonder if we could affect that by maybe modeling it after the college admission process, where you have personal interviews that you schedule in person, or if the pandemic continues, on Zoom, and then have the tours of the facilities totally separate. And they could be actually together for very large groups. And then the other option would be for each residency to create its own video tour, narrated, so the fourth year student could view the facility before even deciding that they want to apply to that place. They'd sort of self-select themselves out and maybe decide, well, maybe that place isn't just right for me. And that might help that big backlog of residency applications that we're seeing.
Yeah, certainly the idea of hybrid models for interview and recruitment is a highly debated topic right now. So for the medical students in the audience, know that there's a lot of discussion right now at CORD, at COPA, on how we're going to move forward with this. I want to check in with Olivia Bailey. What changes have you seen in your program?
Hi, I'm Olivia Bailey. I'm one of the APDs from University of Iowa. In this past interview season, we were actually able to do more interviews. I guess that was an advantage that we saw. And then we also utilized our budget that we normally use for, meals, drinks, day of the interview, and use that to make kind of promotional videos, like Rita was mentioning, to give a sense of the program and the hospital and the people, to hopefully give them an idea of what our program's about without actually being here.
I think that's a very good point. I forgot about all those socials that we would sponsor for the residents to just hang out with the applicants and how fun they were. And then last year we invested. I didn't know that like creating a video like of those promotional videos cost thousands and thousands of dollars. And so hopefully we don't have to do that again next year, so that we can spend that money again on each other, towards each other, and creating this sense of community. Let's check in with the audience to see what additional experiences we've observed. And so again, we're at slide 3. Feel free to take this moment to type in your musings, like how has COVID-19 affected your recruitment process? I'm seeing equitable interviews given, and that's a positive. I'm seeing that Zoom social hours make it difficult to assess culture, definitely, and personalities of the program, right? So when all the lights are on, then you can't like figure out like what is really truly happening in the background. Like they can't be all this happy all the time. And finding that opportunity to get that glimpse is not as easy with Zoom. It's a lot of miss. Finish your train of thought. You're doing great. And by the way, don't worry about the font. Don't worry about the spell check. We just want to normalize that a lot of these things that we're like watching yourselves all the time today, it's okay to just type in your thoughts. Yeah, it's definitely very difficult to get to know the applicants. Anything on the chat? I don't see anything yet. All right, so let's see. So far we've talked about adaptations in the curriculum didactic and how we've also used similar technology to adapt the recruitment process. Let's switch gears again to cover the clinical experience. We've certainly uncovered several challenges during the pandemic. And so specific to acquiring new skills, what were the positives that you saw, Rita?
Well, you know that as emergency physicians, we are the masters of MacGyvering. And this was never truer than during COVID, where we discovered there were a bunch of silver linings that came up. There were a lot of negatives, but there were also very positive, some positives that developed. So one of the things that became evident pretty quickly were attendings and residents had to keep up with all this constantly changing medical recommendations, the protocols, and you know what? We had to quickly learn new skills. Had any of us really done a lot of proning before COVID? No. We learned improved methods of oxygenating. We used high flow. Normally we'd only use that with a lot of PEDS cases, and different ways to intubate. And the PPE etiquette just was not there before we had COVID. And that's become the norm since the COVID pandemic started. So I think handling hypoxia was really one of the silver linings we discovered during COVID. It really improved our management of hypoxia without us just reflexively grabbing an ET tube and resorting to intubation.
Yeah, this can be definitely challenging. I wonder how the pandemic revealed how emergency physicians manage goals of care.
Well, COVID is the great illuminator. COVID uncovered definitely the need for goals of care conversations and discussing all of those end of life care preferences in seriously ill patients. And those are the patients we see in the ED, the seriously ill patients. And COVID also compelled physicians and patients, all of us, to be aware of our own mortality. And so it really prompted our attention to these difficult conversations. Even society as a whole became very aware that the pandemic could have caused scarce resources. And so that even challenged us more to develop these improved conversations that we all hate, but we've got to learn how to do them. So, finding out what a patient is hoping for regarding future care is the crucial piece of information that's necessary before we as emergency physicians can give a recommendation regarding whether a patient wants artificial life support or wants to allow a natural death.
Yeah, interestingly, at University of Colorado, we did something we've never done before. We actually, during COVID, had a pilot program where the palliative care team was stationed in the ED. And they didn't just have conversations with COVID patients, they had conversations with anyone who was fairly sick or needed to be admitted to the hospital. I mean, not necessarily all the, fast track kind of ankle sprains and such, but anyone who was getting admitted for anything else had a conversation with the palliative team. And this opened up the eyes not only of the patients, but of the emergency department staff as to what those conversations look like.
Yeah, Kristen brings out a really good point. It's not for people only at end of life. These discussions are for people that have serious illness. So, and many of you out there may not be aware that a goals of care conversation is an actual procedure, just like an A-line or a chest tube. You would never dream of doing an A-line or a chest tube without training for it, nor would you dream of doing it without writing a note after it to document what you've done. And that is what a goals of care conversation is. It's a billable procedure.
There are some real challenges, though, in training our medical students who are often not allowed into the clinical areas because the potential risk to their health was considered unnecessary. So for a period of time, I know at our institution, it was from mid-March to June, students were pulled completely from the actual in-person rotation and had a virtual rotation with no direct patient care. This limited the clinical exposure of many students, including some interested in emergency medicine at our institution, but they also missed these important conversations that you guys were just discussing. Likewise, some residents were not able to do some of the procedures they normally would do. Some hospitals would have intubation teams that would perform intubations, potentially taking away this procedure from residents who are in training. I was going to say, the great thing to come out of this is that it's been an excellent time to use simulation to kind of do some of these skills or less common skills and procedures to practice through simulation.
Right. But in the beginning of COVID, we didn't know very much about transmission at all. I mean, remember they were telling us when you go to the supermarket, you have to wash every single orange and everything, right? So the faculty were terrified, and we tried to protect the students and the residents. The schools of medicine tried to protect the students, right? But yet the students and the residents felt, I need to learn this stuff. I need to learn these skills. I want to be at the bedside. That's why I'm in medical school. So there was this stress of feeling compelled to do things that you really wanted to do, but you're also afraid to do. And it kind of went against your instincts to protect yourself and your family, but yet you knew you had to learn how to do these things. So there was a lot of stress about not knowing what the future was going to bring. And we did know that people died. And can you imagine the stress if you let a medical student go in and do something with a patient, see a patient with COVID and get exposed, and then something bad happened to the medical student?
Yeah, Kristen, you bring up a very good point. Some call this moral injury. We are asked to be doing something, like we should be doing something more, and now it's in conflict with protecting our own safety.
That's right, LA. Another example of that moral injury that happened was having no PPE and yet being expected to see patients. I mean, you saw that in the pictures from New York where nurses were wearing garbage bags.
Yeah, and so I think right now it's a good time to kind of reflect on our past year, and maybe let's check our post-it board to see what other new skills have we developed during the pandemic. What other experiences have you had clinically that you never thought you would be doing because of the pandemic? We had to adapt. And again, if you're having some challenging experience with the Jamboard, feel free to just use the chat. We're happy to just copy paste that into the board as well. I'm noticing use of inhaled pulmonary vasodilators in the ED. Yeah, definitely. That was not something that I trained in the Bronx. having goals of care discussions over the phone with family. Certainly, that is still happening, and it's not as easy. Proning is definitely new to me as well. Whoever wrote that, thank you. Um, and uh, and many of the things that we've had to do and adapt, right? Like even putting our pictures outside because everybody looks the same now with the masks and the gowns, and so humanizing our experience and showing our patients and each other that there's a person behind that mask. It has been a new challenge. Like I remember before for practicing the PPE for Ebola training, like I listened to it, I didn't really understand. Now I'm like an expert in donning and doffing all of these like PPE because we've had to adapt quickly and because it was so scary that we were seeing this all over. Any other thoughts from the audience?
So just to throw my 2 cents in from my perspective. So my background is as a paramedic educator and a paramedic for 45 years. And the discussion you're having now regarding opportunities to clinical, all allied health professions were shut out of hospitals.
Yeah,
And one of the rationales that was given is there wasn't enough PPE.
yeah,
Makes sense because clearly there were situations when there wasn't enough PPE. But I can tell you in the EMS environment, this is a dilemma that we have anytime we have a student that's doing their field internship. Do you allow them to get close to like the scene of an extrication or get underneath? And I remember when I worked in New York City, I worked at Lenox Hill Hospital, we used to have medical students from Mount Sinai ride with us. And I remember one of them underneath a train with me
yeah,
trying to extricate someone out of the subway, and thinking now in hindsight how dangerous that was because the person had no training about what the third rail was or what
yeah.
kind of things to expect. So the question is isn't EM inherently have inherent dangers itself, whether it be patient violence or exposure to any other infectious type diseases or needle sticks? And we didn't protect students from that or residents. What's the difference and how do we prepare for this in the future, because every healthcare education thing was affected by this process?
Yeah, I love that question, Bill. I'll take a quick stab at it. I think that for me, the biggest difference is that case that you illustrated with the third rail and being under that train. You're right. It puts that medical student at risk, or whoever that student is, that trainee at risk. And at the same time, you know that's that one encounter. We make calculations whenever we teach. However, with COVID, I feel like we didn't really have a lot of those information at the very beginning, and also it was everywhere. It's not like you're dealing with a train that's off the trail track everywhere you go, and you're looking at it and you see it, like you see it in the news, you see it in social media, you hear about it, you get inundated with emails about it. And so everything that we've seen is the catastrophe and the disaster that was happening during the pandemic. And I think the moral imperative for us as caregivers is also to protect our own, or to protect our medical students. And we're realizing now, you're right, that a year into it, we're about to graduate some medical students who may not have had enough close encounters with patients that they would be treating for residency. And I think that is the dilemma that we've experienced. Any other thoughts from the panel?
I think that's something we have to look at really closely because COVID is very infectious, but we are exposed to a lot of other infectious diseases too. And so, and you're right, Bill was saying, and LA, you were saying that COVID was everywhere, but some of our infectious diseases are everywhere too. So, one wonders in retrospect, were we a little overprotected?
Yeah, that's a very good point. Let's switch gears again. As we've adapted our training clinically, we should also consider the impact on job availability and job security. And Jeff, I want to ask you this because you were just applying for jobs. What effect did COVID have on job availability?
Having gone through it the past year, it definitely has had a huge impact on job availability. and even job security over the past year. I think most of us have experienced ED volume substantially going down, dropping revenue, and then also there was just a lot of unpredictability and uncertainty around the pandemic. Academic and community ED groups were having a hard time forecasting their staffing for next year when I was interviewing for jobs, and we're just offering less jobs because of the volatility. Some large groups were even placing hiring freezes. So I know like Kaiser, Northern California had a hiring freeze around here. And it was, at least for me, incredibly stressful to deal with this uncertainty. And I think for me and for many of my colleagues with debt, who have worked 8 years to get to this point, who can no longer have an ideal outcome from employment, was a big challenge. And I'll also acknowledge that what I'm about to say is a very hot topic, but I'll briefly bring this up. I think the COVID job shortages has also uncovered and brought to the forefront the overall surplus of emergency physicians that may occur in the next few years, and generated potential policy changing conversations.
That's right. I mean, even the locums jobs are gone. We used to be able to count on those, right? And some of the EM jobs have turned into telemedicine jobs, and those have taken some of the other jobs away. So job security for emergency medicine is a big deal right now and does significantly impact our wellness. It's very stressful, I think, for everybody.
And Jeff, you mentioned all of these COVID-19 impact on the job market. And again, first, congratulations on landing a coveted job in Hawaii. Can you share with us some of the challenges that you faced in finding that job?
Yeah, thanks, LA. I'm definitely excited. I grew up in Hawaii, so I'm definitely excited to move back home. But it was definitely a challenge finding that job. I think what was most challenging for me was really the discrepancy between the way emergency medicine was being portrayed in the media as like healthcare heroes, and then contrasting that to this very bleak job landscape. I think the benefits, though, is it did really force me to learn a lot about different types of ED groups, how ED groups obtain revenue, the business of hospital contracts, and even alternatives to clinical medicine. And I think that was the silver lining, that maybe I feel more comfortable with some of these aspects of the business side of EM. Because of that, I think from a medical education standpoint, even in non-COVID years, it's really important to integrate these topics early into residency curriculum, just to prepare residents for a diverse job search over the next few years.
Yeah, there's certainly a clear job insecurities due to the COVID pandemic and its impact on the cost of healthcare and the decline of patient volumes. And so no doubt this led to a lot more stressors at home. And so why don't we go there? Why don't we talk about work-life management?
So we all spent a lot more time at home, I think, during this pandemic. And some may say there's not enough time at home, or some may say there was too much time at home. With more time, those with children at home, there certainly was more interface between parents and children. There was an advantage for this increased family time. And for those with children, maybe they weren't rushing from activity to activity and got to spend kind of more quality time together, which I really think has been a unique opportunity from the pandemic.
Absolutely. Wellness to the forefront. And academic productivity was going up despite the lack of research assistants. Some of the pros, again, those silver linings, we know there's sort of always been a tension between clinical and academic work versus time at home with our families, whether it be with kids, whether you're with your older parents, whether you're with siblings. With virtual meetings, though, physicians could skip commuting. And so it allowed families to spend more time together and provide the opportunity for new activities. And when I say new activities, I don't mean climbing a mountain or, running a marathon. I mean something as simple as exploring the neighborhood together, wherever you live, and really getting to know your child, getting to re-know your parent, getting to know your sibling. This very invaluable non-clinical time due to the pandemic is a real gift, and that many physicians seek their whole careers. And so these meaningful interactions between family members and really play a very important role in the well-being of all of us.
One of the big challenges was there really wasn't an opportunity to ever take a break. Many of us enjoy taking vacations. That wasn't possible. Maybe for those that did, they were shamed for taking a vacation. Some physicians had to start their quote unquote work days earlier. Maybe daytime hours were spent helping children in online school or caring for them if there was no school. After this, physicians head straight to work, and that's just kind of life. Especially for parents and caregivers of young children, there was a discrepancy in kind of how much extra work outside of the office they were doing to care, and it was very stressful and hard to kind of get their academic productivity done at the same time.
Yeah, and so with the interest thank you for that. I'm sure this resonates a lot to the audience. And so with the interest of time, we're going to move on to the next topic, but please make sure you utilize the Jamboard to write in your similar experiences as well, or a different experience. Sense of community. So within the department, it seems like fostering a departmental sense of community was a huge challenge because of COVID.
Yeah, I actually think this was one of the most difficult issues with COVID, and I'm not sure that anybody really came up with the perfect solution. We had this huge life-changing stressor that sort of, appeared very quickly that many of us didn't feel prepared for. And normally we would cope and find support through our peers, faculty, co-residents, and friends and family, but especially those at work who were in the ED with us and really understood what it meant to be an ED provider during the time of COVID. And in the time we needed that most, it was taken away. And I think it was even more challenging for those people who were new to the department, like interns or new faculty who didn't have any of that sort of pre-set, network or bond with those people in their departments to form that support network.
Yeah, thanks, Jess. I think that's a very, very important point. And so what were some of the solutions that were implemented?
Yeah, I think at a basic level, a lot of us increased communication through socially distant means such as video chat or FaceTime or Zoom or phone calls or text messages. And I think something else that a lot of us did was just promoting safe outdoor distance activities like hiking or hanging out at a park. And then something we did here was implementing something like an adopt an intern or creating smaller family groups within the residency to integrate new members of the department and make them feel welcome.
Yeah, people did different things involving narrative medicine, storytelling. Kristen, what did your program do?
Well, we did some Zoom happy hours, but we also did these airways sessions where people could tell stories, sharing powerful emotional and stressful and emotional cases. I found that to be very, very helpful. In fact, I heard some this morning earlier on SAEM, just a couple hours ago. You guys did some.
Cool.
Yeah, at Stanford, one of the socially distanced wellness initiatives that we implemented was called Reflection Rounds. And it was socially distanced, it was over Zoom, and it was really to create a space for trainees and residents to discuss their experience with COVID. I think narrative medicine is really powerful, and there's an art and consolation to storytelling. So this way we could create a safe space with peers to really express the challenges with COVID. I think it was like a good way to debrief and delve deeply into a lot of the emotions we were feeling with dealing with COVID. And it was one way to kind of create a sense of community and support system through shared experiences.
So was there any positive then? Like, what were some of the positive outcomes of COVID with regards to community building?
I think most of the negatives we talk about were with the small community that we were used to seeing in person. But one thing that really came out of this was the use of Zoom and these virtual platforms to really get to the broader community. In EM, we were able to reach beyond the confines of our institutions, especially in academic emergency medicine, where like these interdepartmental cross-country collaborations are so important for improving our specialty. And I think that really was brought to light by this increased use of Zoom and our familiarity with it and our ability to connect with each other in seconds. And I do think, in general, because of COVID, even if we couldn't see each other as often, we did get closer with those that were in the department, not just our fellow physicians, but nurses, social workers, case managers, pharmacists, and ED techs, and everyone else who really understood what it was like to go through COVID together.
We suggest continuing to use these virtual platforms we've all become so familiar with to implement personalized wellness interventions such as the reflection rounds previously mentioned, as well as to maintain connections to those geographically far. And all of this is with the goal of continuing to strengthen a national sense of community in emergency medicine. Zoom meetings certainly expanded our reach beyond the confines of each of our institutions.
So thank you. As we wrap up, so what have we really learned from the COVID-19 pandemic as emergency EM physicians? Here's some highlights. Each of us are hitting our own pandemic wall in our own way. And each of us are realizing that we cannot do everything all at once. And that's okay. We never used to before, right? Before the pandemic, we never did everything all at once, nor should we all of a sudden be expected to do more, especially during the pandemic. However, there are a few things that we have control over. We can be kinder to each other because this pandemic has a long-term impact that we're not even realizing at the moment. And this is why this sense of community and belonging is very important. And it's even more important. And so even though this talk is about academic emergency medicine, this is really about our own humanity, our own common goals of care, or as Kristen puts it, our goals of self-care. And so as we move from one Zoom meeting to another, and I know some of you have to jump out, we can look to see how we can be kinder to ourselves and with each other. Because just a wisp of this compassion is healing, and it can promote cooperation and teamwork. And so just as we try to be more patient with the system, maybe we can be more patient with ourselves and with each other. This is where self-compassion comes in. And perhaps we can also experience some gratitude for how far we've come in our job, in our family, our own self-growth, and also the gratitude to simply be able to take care of each other and our patients. Again, speaking of gratitude, I want to end this with this moment of appreciation for spending this time with us. We hope that throughout this talk and our shared common experience has resonated with you, and that it reinforced that we are the community of academic emergency physicians and that you are not alone in this. And so feel free to use the chat, feel free to use the Jamboard to leave your thoughts. And thank you again for your time. And we're at 1:50, we're really on time. Thank you again.